supinated or pronated. Pronation, if the lateral collateral ligament is ruptured, and if we keep in supination, if the medial collateral is ruptured. If it is two, neutral is advised. Dynamic fluoroscopy is important if we have in doubt for the stability. If the joint is stable, early motion should be given. In complex situations, it's important to establish the joint integrity and provide stability. So, in briefly, if the joint is stable, we go to immediate movement. If it is reductible unstable, we are looking at 45 degrees of flexion. And if it is not stable, so we are going to do another options according to surgical options. I'm going to give brief things in my presentation. So if it is stable, so we are going to give an early motion. So in this study, in the conclusion part, early active mobilization is safe, effective treatment for simple elbow dislocations. Patients are recovered faster and return to work earlier without increasing complication rate. So early mobilization is safe and effective. Patients recover faster. Early mobilization does not increase the rate of complications. Plaster mobilizations must be abandoned and motion exercises must begin as soon as possible. How about conservative treatment? Okay, not always satisfactory because most of the patients have pain and stiffness afterwards, restricted ROM, and the patients show 50 to 35% of chronic instability and 35 to 80% persistent pain. So in this study, demonstrate that with the patients are separated in the slight instability and to moderate instability, and they show that the patients that have a moderate instability have a higher need for secondary revision surgery following conservative treatment compared to the patient with slight elbow instability. So we have to separate these moderate instabilities according to do a better, the early surgery and to get a better outcome. So when we look at this conclusion, in 68 patients, slight instability, they have 4-point instability, but in the moderate one, they have 36 instability. So they evaluate it according to the fluoroscopy scan, and this joint is consumed as stable if the joint space is open lower than 10 degrees. And also they have find the drop sign. If it is greater than 4 millimeter, then they assume that the joint is unstable. What is the surgical necessity? As I said before, if more than 30 or 40 degrees of friction is required to keep the elbow in joint space, if the dislocation cannot be placed with close reduction, if the reduced dislocation reduces in the follow-up period, and there is a fracture dislocation and gross instability as well. So there are different types of dislocations, posterolateral and also posteromedial. If unstable, in unstable elbow dislocations, posterolateral dislocations or posteromedial dislocations occurred. and they occur in different mechanism following different damage to the different structures. Therefore, different strategies are needed for different type of dislocations. So for the posterolateral dislocations, if it's unstable, manual valgus stress is proposed, and if it's unstable, then ulnar collateral ligament and flexor muscle repair must be done. And then we are going to recheck the stability during the range of motion. And if it is stable, we are not going to the ulnar side repair. We do the ulnar side repair. We are not going to the lateral side repair. But if it is unstable, then we are going to do a lateral collateral ligament repair and extensor muscle repair. Yani we repair the both repair side. So if we are going to have a valgus stress and it's stable, then we are going to repair only the lateral side. For the posterior medial dislocation, unstable posterior medial dislocation, so we are going to repair lateral ulnar collateral and extensor muscle repair, recheck the stability, and it's unstable. We are going to go to the medial side and repair the ulnar collateral and the flexor muscle, both sides repair, and we finish the operation. So another thing is the mechanism of injury patterns in posterior medial rotatory instability with dislocation compared with posterior medial dislocation of the elbow joint is also different. They have different mechanisms, and the ruptured ligaments are different. So we have to evaluate posterior medial rotatory instability and posterior medial dislocations and separate these mechanisms. So this is our patient. You see a posterior dislocation. So there is a small coronoid fracture. And then we reduce it. And then this is the post-reduction CT. And then on fluoroscopic examination, you see that the joint is grossly unstable. So we begin on the lateral side. You see that there is a rupture on the lateral collateral ligament and also the extensor mechanism. So we make a repair with the anchors. So we evaluate the medial side, but we see that there is a gap. And then we pass to the medial side and put an anchor on the medial collateral ligament as well. So we did on the both sides. So another patient, it's posterolateral dislocation. We reduce, but you see, you see the valgus instability as well. So you see the gross instability under fluoroscopic examination. So we in this patient, we do also both repair from medial and lateral side as well. So sometimes the patients come a little bit late, and after this patient is come 3 weeks after the reduction, but the gross instability you see, we make a X-ray and the patient has a posterior dislocation, persists. On the MRI, we see both lateral collateral ligament and medial collateral rupture. We do the repair on the both sides of the joint. And this is the end result. So sometimes the patients come late with posterolateral rotatoire instability. We have to check them. Some patients persist in instability. So in this patient, you see, as I showed you before, there is a posterolateral rotatoire instability. There is a rupture on the posterior ulnar complex, posterolateral complex, lateral collateral ligament. So we made a graft and we reconstruct the lateral part of the joint. So in order to evaluate the patient, it's important in dislocations, we have to evaluate the patients after the reduction. And if we are in doubt, we have to evaluate in fluoroscopy. If it is stable, we are going to make a early rehabilitation program. And the patient has a slight or a moderate instability. We evaluate the patients. We operate them more quickly than ever. So thank you for your attention.
Thank you. Thank you very much, Dr. Özkan, for the presentation. So we will receive the question and comments at the end of the session. So please leave your questions to the chat box as a reminder. So now we are going to proceed with the second topic. Dr. Atalar, he's going to talk about the coronary fractures. Yes, Dr. Atalar, please go ahead.
Thank you, Gazi. I am Dr. Atacan Atalar. I'm professor at the Acıbadem University in Istanbul, and I am also currently the president of the Turkish Shoulder and Elbow Surgery Society. I would like to first thank again to effort, and namely also Mr. David Lim for making this collaboration happening. Thank you very much. Actually, my topic, coronary fractures, are mainly overcome with the other topics too, because all coronary fractures are problem mainly in most of the complex fractures. We will talk about the roles of the coronary, fracture types, treatment methods, and complications. Coronary makes the elbow a congruent joint. It's very important because it prevents from posterior instability, and this role is shared with radial head, and it's a restraint against varus stress, and this role is also shared with the lateral ulnar collateral ligament. Although my topic is about coronary, but I have to talk always about radial head and ulnar collateral ligament because they act all together to make the joint stable. The insertion of, and it is also with one side, insertion of the anterior band of the MCL. So not only the lateral side, also the medial side that is a part of the coronary's role. How does it resist against the posterior directed vector? If all the muscles get contracted, especially the triceps, biceps, brachialis, the resultant vector makes the ulna, affects the ulna to the posterior side of the joint. So the height of the coronary, it restrains against this and it makes the joint more stable. If it is disrupted, such in these positions, especially with the radial head, then it might be an unstable joint. The other part, if the lateral collateral ligament is disrupted in trauma, and the anteromedial part of the coronoid, it can be also affected, and this is a restraint against varus stress. It's similar like plateau tibia, and it is likewise makes a stability against varus stress. And the third role is the valgus restraint against valgus stress, which makes the sublime tubercle important. It is the insertion area of the medial collateral ligament, where we know also from the valgus, the medial collateral ligament, medial collateral ligament of your injuries. So, coronoid is the the junction of the anterior part of the elbow. So the coronoid fractures are part of a complex injury unless it is proven the other way. So we have to evaluate very good. How? Direct X-rays might be inconclusive sometimes, especially in subtle trauma. If it is a big trauma with dislocation, it might be easy, but in subtle traumas, they are very important. So if we suspect, we need CT scan. It's mandatory in many cases. And also we have to suspect, as I told. In the previous presentation, Dr. Özkan mentioned about the elbow dislocations. If we see at the elbow dislocation a small flak at the olecranon fossa, we have to suspect, and let's see what happens after reduction. There is a gap in the coronoid, and the coronoid part is trapped in the olecranon fossa. It might be important. But 3D CT scan is the most reliable method for classification in both also the X-ray and also the O'Driscoll methods. It's been already shown in this presentation. There are 3 types of classification which are usually used. The historical one is Regan-Murray, which is based on lateral X-ray. When we look from lateral, we see number 1, it's type 1 is a tip fracture, type 2 is until 50%, and type 3 is more than 50%, which is called basis. This 50% is important. And afterwards, O'Driscoll highlighted the 3D CT scan, the importance of the anteromedial part of the anteromedial rim, and also the sublime tubercle. So he added another fracture type, which is called anteromedial. And finally, also again from Mayo, Steinman, he has made another publication, and he has classified the fractures according to fracture mechanism. One is valgus posterior medial, which is also usually a terrible triad with radial head fracture with radial head. The other is varus posterior lateral. There is the radial head is intact usually, but the lateral ligament is ruptured, and said sometimes the tubercle it's been disrupted. And also high energy fractures, coronoid is a part of transolecranon fracture dislocation. This is the third classification. How do we treat? If we have to focus on the accompanying injuries, as I told. What is the position of radial head? What is the position of lateral ulnar collateral ligament? If it is a subtle injury with we suspect of instability, or if it is a fracture dislocation, then we have to make an examination under anesthesia, as highlighted before. Mostly the small tip fractures with stable joint, stable radial head, and if it is after reduction stable, then we can overlook the coronate fragment. But if they are unstable like this, then we have to work on it. If there is anteromedial fracture, according to O'Driscoll, this is a part of instability, so he advises surgery. And also most of the type 3 basis fractures, more than 50%, then we need surgery. This is also this type of approach is also based on some studies which they have also clinically and biomechanically proven that if the radial head and lateral ulnar collateral ligament is fixed or they are stable, and the joint stability is not affected until the 50% of coronate height loss. What can we do if we have to treat the tip fracture surgically? Mostly it's a part of terrible triad. So if we have to fix the radial head or replace the radial head, then we can mostly use the posterior incision to achieve the both sides. And if we replace the radial head with a prosthesis, then it's easier. When we remove the radial head, we can reach the coronate from the lateral side, so we don't need to deal with the medial side. Then we can make the coronate fixation. Then we can deal on radial head, and we can work on ligament. And in some cases, also, if it is very unstable, we can make excessive varus, so we can reach the coronate from the posterior, from the cohort interval, and then we can work on coronate. Then we can return again to lateral side, to radial head and ligament. It is also possible in cases if it is that we have to use the both also medial and lateral, which I will talk now. And screw fixation is mostly enough for larger fragments. It might be antegrade or retrograde phase, and suture lasso or anchor fixation may be used for the smaller fragments. Here's one of my patients. He brought me this after his riding accident, and he came to the emergency room with possibly dislocated but reduced on the way. And there is a coronate fracture with radial head fracture. So we have fixed the radial head first, but after the examination, we have seen that it is unstable. Then we continued with retrograde screw fixation of the coronate. Then after 1 year, we have removed the coronate screw, and he has good function. Another patient, we have replaced the radial head with radial prosthesis, but we have used, because of it is very small, two anchors to fix the coronate fragment. It might be also, if you don't want to use the anchors, it is possible, as David Ring and his collaborators has presented. You can use some transosseous sutures. And what do we do with anteromedial fractures, which is a component of the varus posterolateral rotatory instability? In this position, mostly the radial head is intact. So when we look under fluoro exam, and if it is a larger fragment, we prefer to use the buttress plating for the fragment. And these are some anatomic plates for the coronate, if possible. It can be used, as O'Driscoll also shown, that for the anteromedial side. And you can use the medial approach between the flexor carpi ulnaris, but it's not always as anatomic as taught in some positions. Here's a patient of us, is an old guy. He has simple fall at home and came with a large fragment from the medial side, and radial head was intact. So we have made medial approach with buttress plate with simple 2.7 plate, and he is doing fine afterwards. More high energy traumas or low energy traumas in osteoporotic female patients can be seen in transolecranon dislocation, and coronoid fragment is larger and mostly a part of the instability. This is a high energy trauma after traffic accident, and here you see a large disruption at the in front of the coronoid and the olecranon. So we had work on it, but this is a more typical patient, 58-year-old female after simple fall. She had both fracture dislocation on the posterior side, and the radial head is also disrupted. These fractures, also called posterior montagia in some by some authors, but anyhow, we have to fix all the fractured parts, and this long screw holds the coronoid fragment, and which gives us a stability. And always, as we have in elbow surgery, always our goal is stable fracture with early mobilization is our goal. Sometimes we need salvage procedures if it is unstable. Likewise, we can use the radial head if we want to replace. And also a type of called coronoid prosthesis was propagated in 2010s, but it has not been used as frequent as the radial head. But as Dr. Özkan also mentioned, if we cannot achieve a stable fixation even after these all fixations of radial head, coronoid, and ligaments, then we can use an external fixator for a period where the ligaments or the fractures get healed. How do we do the post-op rehab? It depends on the joint stability, but if all our goal is to achieve stability, and it should be started after 2 to 5 days, and assisted exercises, which has been done by the patient himself, is the main stay. We usually, nearly 100% never send our patients to the physiotherapy because most of the cases, aggressive treatment makes it more, gives a reaction and can lead to joint stiffness too. So the patient is taught to do these exercises on the table without moving her arm and shoulder, only elbow exercises. So we also use ice, sometimes night splint in patients with prone to stiffness, and indomethacin or acetaminophen we still use to, especially in the high energy trauma patients, we use to prevent against the heterotopic ossification. What are the complications? If we cannot achieve a stable joint, it's possible an instability, but it's mostly together with arthritis. Arthritis plus instability, this is a big problem for the patient and also the elbow surgeon. So we have to be aware of having a stable joint. If not, we have to deal with these problems. Heterotopic ossification is mostly seen after high energy traumas, but it is also possible, but it depends mostly on the energy of the trauma and also surgical dissection. So we should be careful not to dissect and not to harm the muscles around the joint. and we have to be very gentle and should know where we have to do the operation. In conclusion, I can tell that coronated fractures are part of the complex elbow injury usually, and the CT scan is mandatory to evaluate the trauma, the injury type. Fluoro exam under anesthesia is indicated, especially in if we are under suspicion and we have to be ready for surgery. And conservative therapy, conservative treatment is indicated if the joint is stable and it is the surgery is achieved. Surgery goal of the surgery is stable fixation, address all injuries, and to achieve a stable joint. And after the scientific events, scientific proofs, we can say that 50% loss of coronate may be tolerated if the radial head and lateral collateral ligament are stable or fixed. Thank you very much.
Thank you very much, Dr. Atalar, for the great presentation, as always. So now, in the previous two talks, we talked about the acute procedures and acute situations of the shoulder trauma. And now we're going to proceed with the persistent complex elbow instability. Professor David Lim is going to give the lecture. Yes, please. Thank you very much, David.
Thank you very much. So I'm David Lim. I'm Second Vice President of EFOT. And first, I'd like to thank you on behalf of EFOT for organising this session and for inviting me. I work at Leeds in the United Kingdom, and the football team isn't any good nowadays. So I'll tell you a little bit about Leeds. It's the second busiest trauma centre in the UK, and we're also regionalising elbow services. So we are a hub for elbow arthroplasty surgery. So we do a fair amount of elbow work. And I've been asked to talk to you about persistent complex elbow instability, when to reconstruct and when to replace. And of course, everything we're talking about now, the bony lesions, the ligament lesions with instability, means that we're going to overlap between the talks. And I apologize now if you've heard some of what I'm going to tell you in the previous two talks, but at least it should reinforce it. So I can start off with a summary slide, which tells you my thoughts on this. Persistent complex elbow instability, when to reconstruct, almost always, and when to replace, almost never. And we could end the talk there, but I think we should probably go a little bit further and give some reasons for that. So how do we define complex instability? Well, there are three real categories, and we've heard about all of them already, really. The main ones are the posterolateral instability that would be described as the terrible triad, or was known as the terrible triad. Anteromedial instability, which has been more recently described by O'Driscoll and developed from there, where you tend to see a coronoid injury plus lateral ulnar-collateral ligament injury, and the transolecranon fracture dislocations, or the Monteggia variants that we've just heard about in the last talk. And we've already heard a bit about the mechanism of the terrible triad, where a common cause of it is that there is a fall on the extended supinated arm, and the elbow goes into valgus, but it rotates, and it rotates so that the radial head goes backwards. And in many cases, it's thought that the lateral ulnar collateral ligament tears in an early stage of this sort of injury. And the radial head starts to move backwards. Now, what happens then depends on the position of flexion of the arm and the force that's coming axially along the radial head. Because if the radial head is axially loaded, but the elbow is relatively flexed as it goes backwards, then you tend to get a shear fracture of the radial head. But if the elbow is more extended, there's a larger axial force as it goes backwards, then you tend to get a more comminuted radial head. And if this is severe, you can end up with an Essex-Lopresti type lesion too. But once the radial head has escaped posteriorly with the lateral ligament tear, then the capsule begins to tear across the anterior aspect of the joint as the forearm rotates into a sort of excessive supination position. It tears across and the subluxation of the coronoid then starts to happen. And you get a similar situation here where if there's an axial load through a relatively flexed elbow, the coronoid can dip underneath the distal humerus and either not fracture at all, or you just get a fracture of the tip with the capsular attachment. But if the elbow is relatively extended, then you can get a much larger segment of the coronoid fractured off, the type 3 fracture that we've seen. And finally, in this particular mechanism of elbow dislocation, the medial ligament might rupture also. So the bony elements that we're dealing with in a terrible triad injury are the radial head stroke neck fracture and the coronoid fracture. Is that all? Well, the parts that we reconstruct include the soft tissue elements, which are the lateral ulnar collateral ligament rupture, and the capsular tearing, which involves the coronoid tip segment. And we've seen that we often end up repairing those with suture anchors. And finally, the medial ligament rupture in some but not all cases. But there's another bony lesion, and we've seen it on some of the X-rays and the MRI scans already, because when the dislocation begins and the radial head subluxes underneath the capitellum, it can create a bony lesion on the posterior capitellum, so that when the radial head is reduced, we have a defect on the posterior capitellum, and that defect is called the Osborne-Cotterell lesion. And when we're dealing with chronic instabilities, particularly, this can be a real issue. And I think it's quite like the Hill-Sachs lesion on a humeral head, really, in recurrent shoulder instability. You can have matching defects, segmental defects of the radial head that perhaps you just excise, thinking that's a small lesion. But you also get an Osborne-Cotterell lesion where there's a missing segment of the posterior capitellum. And depending on the position of rotation of the forearm, you can line up the radial head defect with the Osborne-Cotterell lesion and develop recurrent instability in the same way that you can have problems with on-track and off-track Hill-Sachs lesions. So don't forget the Osborne-Cotterell lesion. And this is much more important when we're dealing with chronic instabilities. So we'll add that to the list of lesions that occur with the terrible triad that we might have to deal with the reconstruction. So that's the sort of pathoanatomy of one form of chronic instability. The anteromedial instability, and again, I'm not being all encompassing in the description of the mechanisms. We've already had good descriptions of that, but what tends to occur with anteromedial instability is that the ulna is forced into varus, and this ruptures the lateral ulnar collateral ligament. And as the ulna swings into varus, the medial facet of the coronoid impacts against the trochlea and a fracture occurs. And so if we look at this simple diagram, we've taken the radial head out so that we can see the medial ligament attaching to the facet on the medial coronoid. We can see the lateral ligament more posteriorly placed behind the radial head. And as the ulna is forced into varus, the lateral collateral ligament ruptures, the impaction occurs of the coronoid, and fragmentation occurs. We've seen some good CT and MRs in earlier talks that show what can be very subtle signs of this, because the case that I remember most that I've treated with this sort of instability had fallen on a skiing trip. He'd had his elbow, he never even went to have it treated by reduction, but he came back and his elbow was not letting him return to sport. And the only radiological finding was that on a plain AP X-ray, you just couldn't see the medial border of the coronoid. Everything else about the elbow looked perfectly normal, but he'd impacted and lost his medial coronoid with a lateral collateral ligament rupture. So that's the sort of pathoanatomy of the anteromedial instability. And finally, the Monteggia variants, the transolecranon fracture dislocations. The pathoanatomy of these is whatever's happened to the bones, really, and I won't go into it in great detail because for most of these, the question of replacing and reconstructing doesn't come into it until a much later stage, because for these we will be trying to reconstruct. But because the lesion is usually an olecranon fracture with that allows the humeral shaft to pass through the olecranon fracture, the radial head dislocates either anterior or posterior. So we are often dealing with bony lesions and the ligaments are intact. So moving on really from the pathoanatomy to the treatment, we'll talk briefly about the transolecranon fracture dislocations because I will have less to say about these. The treatment is going to be to reduce the dislocation first and foremost, and if there are any open wounds, then we deal with those. But if there are any open wounds, that's an ideal opportunity to look at the humeral articular surface, because if you are going to get any problems with the need for arthroplasty in these patients, it's because of the damage to the humeral articular surface that's occurred. And it's often shearing off of the cartilage, not necessarily with any visible bony lesions on plain X-ray or even on CT scan. So do check the articular surface of the distal humerus. The rate of arthritis in these injuries is surprisingly low. I think that we probably see a nasty olecranon fracture with some sort of instability. Well, we certainly see the nasty olecranon fractures where you think the articular surface of the elbow is severely damaged, probably once a week or once every 2 weeks in the hospital I work. And me and one of the surgeons do all the elbow replacements for our region, not just our hospital. And the number of times we have to do an elbow replacement for the consequences of this sort of injury is virtually never. And I think that's because, as we know from the biomechanics of the elbow, the articular surface with the ulna is the olecranon facet at the back and the coronoid facet in the front, and there's often a bare area in between. And so long as you can reconstruct these fractures with the olecranon facet and the coronoid facet articulating congruently with the distal humerus, then you tend not to get arthritis that goes on to need elbow replacement. So the real treatment of these injuries is to fix and reconstruct the fractures, paying particular attention, and we've already seen this in some of the earlier talks, to good solid fixation that connects the olecranon fragment to the ulnar shaft and replaces the coronoid fragment in the right place. And you can graft or you can reconstruct the mess in between, but so long as you've got the olecranon fragment, the coronoid fragment, and the shaft all in good alignment, then you often have a stable elbow that might not have the full range, but often doesn't then go on to develop arthritis needing joint replacement. If we move on to treatment of the other sorts of complex instability, we can have a look at posterolateral instability, where my recommendation would be to reconstruct, and anteromedial instability, where my recommendation would be to reconstruct. And I've already said that for transolecranon and fracture dislocations, we would reconstruct. And my approach to posterolateral instability, I used to do posterior approaches to be able to get to the medial and the lateral side. I've gone away a lot from repairing too many medial ligaments because my experience was that you tend to get heterotopic ossification into the repair site. And unless the elbow is very unstable, I would aim not to do that. So I try to approach the posterolateral instabilities from the lateral side. And through the lateral approach, and we've already heard this as well, the first thing you encounter is the avulsed lateral ulnar-collateral ligament. It's almost always come off of the humerus, not always, but almost always, and it may have taken off the common extensor origin as well. The next thing you see, the capsule's torn, so you see the radial head, and I think that's the time to make your decision about whether you're going to fix or replace it. You don't have to do that now, you just have to make the decision, because it helps you with dealing with the coronoid, because if you've already decided that you're going to replace it, then at this stage you can take off, you can make your cuts for the radial head, and that gives you access through to the coronoid. We've already seen good examples of fixation of the coronoid, and the access to it in this sort of injury is remarkably easy, because you just have to supinate the forearm. It's already unstable, so the radial shaft, radial head moves posteriorly, and you're looking at the bed of the coronoid fragment, and you can put drill holes through that for transosseous sutures, or you can put anchors into it, as we've already seen. Prepare your fixation, but don't tie anything yet. Don't fix the coronoid. Just place the sutures, place the anchors, and then reduce the elbow, and then come back to deal with the radial head. And so you might do a fixation of the coronoid. You might screw fix the radial head or whatever. The Osborne-Cotterell lesion, you will see this at this stage, and my experience is that you don't know if it's going to be a problem. And I think I've once ever can remember there being a large discrete fragment that I fixed back with some absorbable pins in the acute stage. I must say all the other times I've treated Osborne-Cotterell lesions have been in reconstructions of chronic instability. So after fixing the radial head, you can tie the coronoid sutures or fixation if you've used suture anchors or transosseous sutures. And the final step is to repair the lateral ulnar collateral ligament to the isometric point, as we have already seen. If you're going to replace the radial head, there are a few technical aspects to think about, because I know that radial head replacements are called anatomic replacements quite often, but none of them really are anatomic. Or if they are, it's purely by chance that they are the precise anatomy of the natural radial head. So we're not born with radial heads that jump in 2 millimeter increments. So if we're looking to replace with a prosthesis, if there's any doubt, use the smaller size. Don't put a larger diameter radial head in. That will cause you problems. The length of the radial head, it's important not to overstuff. And you can see on this X-ray, typical X-ray after treating a terrible triad where you've got your anchor fixation of the lateral collateral ligament, you've got a radial head replacement in, but the ulnar is subluxed over, it's pushed over to the medial side. The lateral aspect of the ulnohumeral joint is open, and that's an overstuffed elbow that's going to have a limitation of the range of movement, and it's going to be painful. So try to check the length of the radial head carefully. The disc should be at the level of the lateral coronoid, and you can see that while you're operating. And check the tracking as well. Sometimes, especially for the uncemented radial heads, the reaming angle of the neck can affect the tilt of the radial head, which can affect the tracking, and you can adjust that very slightly with some prostheses, depending on the sort of prostheses that you've got. Fixation, there's a lot of debate about that. There's an argument that cement fixation means that the prosthesis is more stable and you get less forearm pain, but then it can't self-align for tracking, and so it can cause more radiocapitellar pain. I've never used cemented prostheses, largely because I don't fancy having to revise them. But there is also a question now about the role of bipolar prostheses. For anteromedial instability, we have to think about a range of things. And if there is a large coronoid fragment, then this would be one where in the acute phase, I would use a posterior approach. Through it, I'd mobilize the ulnar nerve. I'd go through the bed of the nerve, usually transposing the nerve, and fix the coronoid through that. And we've seen examples already of how to fix the coronoid. And then, because it's a posterior approach, you can go over to the lateral side and repair the lateral ligament that is also ruptured in anteromedial instability. If you've got a small or comminuted coronoid fragment, then through a lateral approach, direct repair of the lateral ligament should be possible. I guess from my point of view, that's a theoretical possibility, because I can't recall ever having met a patient with this sort of instability who I've met in the acute phase, who I've decided to operate on when they have tiny, tiny bone lesions. They're usually treated initially as patients with elbow dislocation and take it from there. And I can't recall many of them having any problems with it. But later, for the chronic problems, when they do arise, then we've seen options for that. The approach is dependent on the reconstruction that you're going to carry out, but the mainstay is lateral ulnar collateral ligament reconstruction, and we've seen examples of that. I have grafted the coronoid with radial head, actually, on one occasion. I have never even seen those interesting looking coronoid prostheses that we saw in the last talk, but perhaps that's because they have gone out of fashion or they didn't work very well. But reconstruction of the lateral ligament is the mainstay of treatment, and palmaris longus would be my choice for that if the patient has got a palmaris longus tendon. There are many, many different operations for reconstructing the coronoid, and the reason for that is that it is very rarely required. Not many surgeons in the world have a significant experience of it, so they all have their own ideas and try something. And my philosophy usually is that if there are a lot of operations to treat a particular condition, then the reason for that is that because none of them work, so everybody tries something different. So I'd say that the only reliable part of this management is reconstructing the lateral ulnar collateral ligament, and whatever you do with the coronoid is kind of experimental. The most recent case I did treat with lateral ligament reconstruction, actually, and just to mention it here, is the one with the varus elbow. This is after a childhood injury with a gross varus, and sometimes you have to add in a valgus producing osteotomy to protect your lateral ligament reconstruction. That's just something that's unique for patients with a gunstock deformity after childhood injuries, just to connect with the talking children's earlier. So moving on to the replacement part of it, when do we do an elbow replacement for complex instability? Well, the evidence for this is minimal, actually. I refreshed my last literature search specifically for this talk, and there isn't much out there in the literature. And what is out there in the literature is almost unbelievable. And that's this paper from Dr. Baxi in India in 1998, who in the British JBJS, and I guess I would have been on the editorial board then, I'm on the Council of Management now, published this paper on sloppy hinge prosthetic elbow replacement for post-traumatic ankylosis or instability. And if we believe this paper, we should replace more. And I'm not sure I believe the results of it. I don't know why, I don't know what it was about his population, but the results seem to be very good. He had 79 patients, with post-traumatic problems, and 11 of those were unstable elbows. The mean age was 28.6 years, and he followed up these patients for 9.6 years. So that's a huge experience, I think, for this problem, which is a very rare problem. And he described 9 out of 11 good results, 1 fair and 1 poor. And considering that this is a very difficult problem to treat, that does sound like extremely good results. But I'm not quite sure what good, fair and poor meant, because if you read the text of it, there were significant complications in more than 20%. And although he doesn't really describe many failures, he said that patients who had loosening or late revision had remarkably stable elbows because of fibrosis of the approximated bone ends, restoring balance and stability. I'm not sure that sounds like a good result to me. So the literature is very difficult. Most of the cases described are in one paper, which is difficult to comprehend in terms of the population. The biggest cohort of elbow arthroplasty patients is the UK National Joint Registry. I'm sure there will be further ones coming along with bigger cohorts, but at the moment we've got, I think in 2019 actually is the last year with full data, 4,373 elbows with that are followed up. And if we compare those, the population, if we compare to Baxi's paper, he had 79 patients. One surgeon found 79 patients, all from trauma, with a mean age of 28.6 years treated by arthroplasty. In the National Joint Registry for 2019, inflammatory arthropathy was the commonest indication. Acute trauma, there were only 85 in a year across the entire UK National Joint Registry. So 79 patients from one surgeon is huge. And the trauma patients were almost always post-traumatic osteoarthritis, and the average age was 68 years. So considering the amount of elbow trauma that we get, it doesn't seem that instability needing elbow replacement is even recognized as a category in the National Joint Registry. So I think that the number of cases that need it is very small, and my personal experience would also be that the number of cases needing it is very small. And so if there's no real scientific investigation, evidence is just people's opinions. And my opinion on the indications for elbow arthroplasty is, well, there might be some in the transolecranon fracture dislocations with significant injury to the distal humerus in the elderly and low demand patient. But usually you would be reconstructing those. It would have to be a very unusual combination of bony injuries that made you want to do an elbow arthroplasty. And the other main indication is failed reconstruction with recurrent instability causing arthritis. So it's something you're going to be doing as a secondary problem down the line. The other indication is repeated dislocations in the elderly or osteoporotic. And I think this is the sort of case that we may have seen, where you reduce the elderly patient's elbow, but it comes out in the plaster cast. So you try and reduce it out, it comes out in the plaster cast, and you're thinking, what's the bone quality like? when you have an X-ray like this, and this is a patient of mine, 80 years old, nursing home resident, did use her elbow to feed and dress herself, so it was useful to her, but she was in a lot of pain. And now, are we going to do ligament reconstructions in this 80-year-old lady and try and reconstruct a coronoid fragment in osteoporotic bone? Well, no. Actually, just pop in an elbow replacement for this sort of patient, and it just solves the problem for you. So it's a really good treatment when you need it. You just don't need it very often. And if you do need to do an elbow replacement for instability, it's an easy elbow replacement. The ligaments are torn. I would almost always use a triceps on approach so that you can mobilize them immediately. And the one thing I would agree with the Baxi paper is that you need a sloppy hinge prosthesis, and I would use the Coonrad Murray, but other prostheses are available. But the real issue related to elbow replacement is that patient selection is paramount, and I would not choose the 28-year-old patient on average. I would choose the 80-year-old with low demand, and for all other patients, attempt reconstruction. So just to summarize once again, the take-home message from me would be that for persistent complex instability, the answer to when to reconstruct is almost always, and the answer to when to replace is almost never. Thank you.
Thank you very much, David, for that great and very clear presentation. So we can proceed with the questions. We have one question to Dr. Özkan. If following the reduction of the elbow, if the elbow is stable, do you recommend the elbow brace? And if you recommend, how do you manage it? How long? And how do you proceed with the range of motions for the simple dislocations, I think? Can you turn on your volume, please?
Okay. After I reduced the joint, I put a extension splint for 20-25 degrees and begin to flexion movements immediately. And then after 2 weeks, so 3 weeks, I'm going to take out the splint and begin to extension movement as well.
So you prefer to start the range of motion immediately, right? Immediately. So what's your opinion, Dr. Limp, about the gaining the range of motion? Are you a preservative surgeon or more aggressive?
For simple elbow dislocations, I would usually begin mobilization immediately. We have just a printed sheet that we give patients that we put them into a collar and cuff with the elbow at approximately 90 degrees. We allow them to flex up to full immediately. And then after 2 weeks, we lengthen the collar and cuff so they go from 60 degrees to full, and 2 weeks more, 30 degrees to full, and after that, no restrictions. So they have a printed sheet. They come back if they have any issues or problems with it, but I would go for very early mobilization in simple elbow dislocations. If there's any instability, then I would use a brace.
Okay. Yes.
Can I make a comment? The problem is for the elbow dislocation, the patients gain extension a little bit. It takes time. So I try to make the extension after 2 weeks or 3 weeks time to gain the extension as well.
So I have a question to Dr. Atalar. How often do you use the coronoid plates? Are you familiar with these plates? Because there are some different types of the plates. Which design do you use or recommend to the audience?
Thank you, Gazi. Very, very rare, I can tell, because Actually, I'm not working, or in the Turkish system is not as the UK system. We're not having trauma centers. So occasionally, if we see varus, I mean the anteromedial and sublime tubercle fracture with a large fragment, so I'm trying to use it. But I always do be ready for the anchor fixation or other fixations, because most of the times the plates are not as anatomic as on the other parts of like distal humerus or olecranon. So you have to be ready for reconstruction. And most of the times also the patients come to me later, like 3 weeks, 4 weeks later. So the fragments are small, and if you put the plate on it, it gets also squeezed. So stability is more important than that thing. And in larger fragments, also simple plates are enough for stability.
Thank you very much. So we have one more question to Dr. Limp. Does he think that is there a role for elbow fusion in the case of complex elbow dislocation sequelae? Through this,
I know. Yes, I guess I must say yes to that, because I always discuss it with patients as an option, and I even have currently, although she's not a patient with complex instability, she's a patient with rheumatoid disease, a patient who has asked me to do it. But what I also do before fusing elbows is put the patient into a cast in the position that they want to have it fused in, and say live with that for a couple of weeks and see what it's going to be like for you with a fused elbow. And nearly always the patient will say, actually, no, I don't want it fused. So I think I've fused elbows where there's severe trauma in young people with a totally destroyed elbow, but very, very rarely. And most patients will themselves choose against it. So I discuss it, but very, very rarely do it.
I have a question to Mr. David Limp. You have mentioned about the diameter of the radial head. You use the smaller in case of if you are in between, but the length is, as you have shown, is more problematic, especially in the patients. The lateral collateral ligament is already disrupted, and when we make the trial, we see that it's good, but it's already in varus, or in the setting of Montegia, when we do it from posterior. Do you have any clues or tips for giving us to maintaining the length of the radial head prosthesis?
What you mean when the neck is coming out, or
yeah? How do you decide you have arrived the correct length in the operation?
So I do it by looking at the facet for the proximal radial ulnar joint, because when the radial head is out, you can see the facet on the side of the ulna for the radial head, and that is a fairly accurate alignment, I think, for the length of the prosthesis. And if in any doubt, as you sometimes, and I'm more worried about the combination of the neck, where it might change afterward. If in any doubt, I would just pop in the trial and just flash under the image intensifier and just check that you haven't got any opening at the time. I think there are all sorts of things you can do visually, but if in doubt, just check with the image intensifier.
Yeah. Can I?
Yes.
It's better to look at from the image intensifier to the motion, while you are taking the lateral collateral ligament a little bit straight, and then look at the motion. Then you can adjust the length of the radial head prosthesis. Lim, I want to ask a question to you. Do you, in the chronic instability, do you have experience about the box loop technique with the graft to take the graft from medial to lateral to the olecranon as well?
Yes. We do box ligaments. Strangely, we've done quite a few recently, and also with distal humeral hemiarthroplasty for complex problems. We sometimes, because the hemiarthroplasty components allow you to put a box ligament through the humeral component, and then you can reconstruct medial and lateral ligaments as well. So it is something that I do have experience with. It's for the most complex cases, so it's impossible to tell the results because you don't get a uniform set of patients. So the one I've most recently done is one that failed. I know she's failed already because then she was a third time attempted reconstruction that had come from another hospital, a very large lady with valgus elbows. We did an osteotomy and a box ligament reconstruction at the same time, and she still feels lax. You can't use palmaris longus, it's not long enough for a box ligament, so you either have to use a hamstring graft or an artificial one with interference screws. But yeah, it's interesting.
Can I add something about box loop? We have to discuss with the patients that their elbow after this type of huge instability, not as a normal elbow, but their elbow does not dislocate anymore, but they are not as stable as a healthy elbow, as far as in my hands in this box loop reconstruction.
Yeah, I have a question for the whole speakers. I want to clarify your decisions about when do you prepare an external elbow fixator to the back table while you are doing an elbow instability surgery? Always, never, sometimes. So what is your indications? How do you recommend to the young elbow surgeons? Yes, Dr. Özkan. As I showed before, I evaluate the patient and I evaluated in the fluoroscopy as well. And if there is a gross instability, I always take insight to the external fixator. What is the percentages of to use an external fixator in elbow instability and fracture? It's not so much because when you reconstruct the radial head, lateral collateral ligaments, sometimes you don't need to go to the medial side. So if you go to the medial side, then you could reconstruct it as well. Sometimes this kind of patients needs a kind of external fixator. Yes, Dr. Akalar.
Yeah, I would prefer I can tell you in every terrible triad case, because it is not all the patients are unique. So it's a small box. It's only 4 pins and a small hinge. So I always prepare in cases with terrible triad cases, and also the transcircumferential fractures, especially the high energy ones.
Mm-hmm. And how is your experience, Dr. Lim?
I'm trying to think. I used to use it a lot, and I used to use the hinged ones. I used them for distraction arthroplasty for stiff elbows. And so I always used to put them on reconstructions, but I can't actually remember the last time I used one. I've sort of stopped using external fixators, except in open fractures where you might want to let the soft tissue resuscitation happen. I haven't got a good reason why I've stopped using them. I've just sort of drifted away from them with time.
Great. Thank you very much. I'm just checking the chat box if we have more questions or queries or comments. I see there is no more. And if you don't have an additional questions or comments, I want to close the session. I want to say again, thank you very much. And we are very happy to see you to have efforts also to our Turkish Shoulder and Elbow Society Congress. Hope in the future we will improve our collaboration. Thank you very much.
Thank you.
Thank you. Thank you.
Thank you.
Bye-bye.
Okay, bye-bye.
Bye.